Hi, I'm Dr. Sean Burke, and I'm here today with Dr. Jeff Volek and Dr. Steve Phinney to explore low-carbohydrate lifestyles and diets. First question is, how are low-carbohydrate diets different from alternatives?
Well, there are a range of diets available for people to choose from, and I think it's an important point and principle that people vary widely in their ability to tolerate carbohydrates. So a key to finding the most appropriate diet for a person is finding what level of carbohydrate tolerance they have. And so one person who may be able to tolerate more carbohydrate would do very well on a high carbohydrate, perhaps Ornish type diet, or even the typical American diet that's higher in carbohydrate, whereas another person may do very poorly on that diet. So there's no one perfect diet. What we've learned empirically and through many research studies now is that people who have insulin resistance, so metabolic syndrome or type 2 diabetes, do much better when they restrict carbohydrates. In fact, their disease, the process of insulin resistance in the body, manifests itself functionally as a form of carbohydrate intolerance. So intuitively, if you have an intolerance to a nutrient, such as lactose intolerance, gluten intolerance, you avoid that nutrient. And so when we describe the condition of insulin resistance as carbohydrate intolerant, I think most people will understand that it's very rational then to restrict that nutrient. And in fact, when we do that, we see that many of the features of insulin resistance improve, and folks respond very favorably to that type of diet. So it really depends on the person in terms of what they respond most favorably to.
And how about even for people without insulin resistance? Why would a low-carb diet be more effective potentially?
Well, I think from a evolutionary perspective, we are hardwired to respond to a low-carbohydrate diet. So even if you're insulin sensitive, especially if you're insulin resistant, you can adapt to removing most of the carbohydrate out of your diet if you follow that diet for more than a couple weeks. So in that regard, every person, I think, has the ability to adapt to a very low carbohydrate intake.
And the way the body differs is when we consistently eat carbohydrates, carbohydrates become the body's first line fuel. That's what the body is expected to burn, in part because we can store very little carbohydrate in our bodies. So if you eat a fair amount every day, that has to go to the front of the line to get burned, which means that fat gets kind of blockaded and put in reserve. That's what extra adipose tissue is reserve. When you restrict carbohydrates, as Jeff said, for a few weeks, the body goes through an adaptation process, and now fat becomes the body's first line fuel. And it becomes the body's, in essence, high-octane fuel. It doesn't happen overnight. It takes a period of time for that to occur. But what differs is the basic fuel flow system of the body. And as Jeff implied, from a evolutionary perspective, whether humans lived as hunters and ate very little carbohydrate, or whether they had to go through periods of prolonged fasting in between crops if they were subsistence farmers, there have been periods of time in human history where all of us have been, our metabolism had to adapt to a low-carb situation. And the human physiology is very adaptable to get through that, given, as we say, that modest period of time to make the switch from a high-carb fuel system to a high-fat fuel system.
So what would you say constitutes a good low-carb diet for weight loss?
Again, as implied, people vary one from another. The people have diseases or conditions associated with insulin resistance or carbohydrate intolerance have to get quite low in their carbohydrates. Doesn't mean zero carbs, but when we do it in grams per day, you get into this adapted state. We call it keto adaptation because the body starts making ketones when you get low in carbs, under 50 grams a day. But we know people who are very insulin resistant, patients or colleagues of ours, and again, some of our most interesting patients are fellow physicians who are doing low carb, that they have to be under 25 grams of carbohydrate per day to be on a diet that allows them to get into the sustained fuel flow where fat becomes the body's primary fuel. So for one person, it might be 25 grams a day if they're severely insulin resistant. For a person who's carbohydrate tolerant, then maybe they can eat 100 or so grams of carbohydrate per day, still get the benefits of a modest degree of carbohydrate restriction. So there's no one perfect diet for everyone. It really has to be individualized to allow each person to find that, shouldn't say sweet spot, but I will, sweet spot for them dietarily that lets them feel and function well.
And would you say that could vary with age as people change from their 20s to their 40s to their into the 60s even, that could totally change throughout their life?
I resemble that. I think there was some cat who said that in a cartoon. When I was in my 20s, 30s, 40s, up to my early 50s, I could tolerate vast amounts of carbohydrate and do just fine. When I passed the age 50 threshold, I started gaining weight in the middle, I started gaining blood pressure, and using all the best techniques of, quote, balanced diet, using high fruit and vegetable and low saturated fat and lots of dairy, low fat dairy, all the things that are supposed to control blood pressure. My blood pressure was getting to a point where it was dangerous. And the only way I got my weight and my blood pressure under control was switching to low carb. And I stay under 50 grams per day and have done for close to a decade now. So for me, the diet that served me well in my youth did not serve me well in what I now consider my middle years.
And can you talk mechanistically about how carbohydrate restriction or limiting carbohydrates would help manage blood pressure, for example?
That's a wonderful question. And we're actually working with a nationally recognized nephrologist who's collaborating with us on a current, Jeff and I, on a current study. We do know that in studies done on total fasting in humans, done 50 years ago, that when you put a person on total starvation with no calories coming in at all, the ketone levels in the body get up to...
Before you go on about ketones, tell people what ketones are for those who don't know.
Okay. If you ask most dietitians or doctors, they'll tell you that ketones are toxic byproducts of fat metabolism. And that's because most of us trained in clinical medicine learn about ketones in the context of diabetic ketoacidosis. That's ketones up here, numbers of 15 or 20 on a test. My ketones, nutritional ketosis, are here in the 1 to 3 range. Okay, so this is ketoacidosis. This is a flood that sweeps away villages and bridges and highways and stuff. This is a modest, gentle rain that nourishes. Starvation ketosis, that is eating no calories but not being diabetic, is in this range. With starvation ketosis, the kidney's handling of salt changes dramatically. It turns out when you eat carbohydrates and you're carbohydrate fueled, your kidneys retain salt. When you're keto adapted, your kidneys switch and dump salt.
And part of the reason that helps treat blood pressure?
And that appears to be part of the reason that it treats blood pressure. But the other is that the tone of the blood vessels themselves change. And Jeff has done actually some pioneering work in that. And maybe you want to talk about vascular compliance.
We've had an interest in a number of biomarker responses to low carbohydrate diets, including vascular function and blood pressure. And we do see a very consistent lowering of blood pressure. Delving a little deeper into the mechanism, I would agree with Steve that there's this natriuresis effect, and some of the reduction in excess water is contributing to the lower blood pressure. We've actually looked at the functioning of blood vessels using a technique called brachial artery reactivity that measures how the major artery in your arm responds to a hypoxic stimulus. And it's a rather standardized and routine test that's done in studies looking at how well blood vessels function. And anyway, we put people with metabolic syndrome on a very low carbohydrate diet to induce nutritional ketosis for 12 weeks, and we measured how well their vessels responded after that time period, and we showed that they actually improved compared to a more traditional low-fat diet, a group that followed more or less the American Diabetes Association, American Heart Association type diet. We also looked at how these vessels responded after a meal, very high in fat. There's a number of studies that show when you eat a McDonald's meal or a high-fat meal that you see this dysfunction in the way the blood vessels respond, and so many people will teach away from fat because this single meal caused vascular dysfunction. But coming back to the term Steve introduced, keto adaptation, when you allow people more than a couple weeks of consuming this type of diet, you have a very different response to that same high-fat meal. And instead of showing a dysfunction, you actually show an improvement in the way these blood vessels respond to stimuli. So you're improving actually endothelial function. These cells that line the vessels that release nitric oxide are actually functioning at a more beneficial level.
And that raises an important point. When you hear about research on diets and people talk about, oh, there was a study done, actually it's last year, one done in the British Isles with that proved that a low carbohydrate diet was bad for you. But it was a four-day long study.
Right.
You know, if they'd done a 4-week-long study, they almost assuredly would have gotten the opposite result. But A, it's cheaper to do a short-term study, and B, if you want to prove, if you set out to prove that a, quote, Atkins diet is bad, do a 4-day study, and you can probably find things that aren't functioning all that well in those 4 days. But if somebody has 30 or 40 excess pounds of body fat, and like me had high blood pressure that was getting to a dangerous level, you know, if you make the investment of getting through that adaptation period of a few weeks, and then you get to a place where you feel well and function well, and you take away the carbohydrate blockade of fat, so you open up the body's ability to burn fat as its primary fuel, then you enable that person to get to a much healthier state. Now, I would ask you, which is more dangerous, being at day 4 in the transition phase of a low carbohydrate, or getting through that transition phase and shedding that very dangerous central fat that us guys tend to collect and carry, and with it the side effects that we have of hypertension, high blood sugar, all those things that eventually potentially lead to diabetes.
So let's talk more about the keto adaptation phase, but before that, are there any tests that people can do to measure whether they're carbohydrate intolerant or carbohydrate sensitive, as it were? Anything that anyone can go out and get tested in a lab, for example, that would tell them whether they should be on a low-carb diet, both short or long-term, or on a higher-carb diet?
The available test that's been demonstrated over and over to be an effective measure of that is something which is a calculated value called insulin resistance. So you measure in a fasting state, you measure blood sugar and you measure blood insulin levels. And the question is to hold your blood sugar normal, how much insulin does your body have to make? And if you are insulin sensitive and you want to hold your blood sugar here, then if you're sensitive, you keep your insulin down here. But if you're insulin resistant, you might still have the same blood sugar value, but it takes an insulin up here to keep it down there, to hammer it down there. This person's insulin resistant, and that person, it will be, by analogy, carbohydrate intolerant. If you have a normal blood sugar and a lowish normal insulin, then you're sensitive. And in a study done actually here on the peninsula by Dr. Chris Gardner and published in the JAMA back in 2007 called the A to Z study, Dr. Gardner put people on either high carb, intermediate carb, or low carbohydrate diets and followed them for a year and published that data. And the low carbohydrate diet people on average did better, not just initially but over the longer term for many risk parameters. After he published that paper, he went back and re-examined the initial data, and what he found was that when people were insulin resistant, and if you put them on a high carbohydrate diet, they did very poorly. If they're insulin resistant and they put them on a low carbohydrate diet, they did very well, which says that the insulin resistance is a predictor of how well you respond, and that carbohydrate restriction appears to be the better alternative for somebody who has this even normal blood sugar but high insulin value. That's I think the best current test we have available.
And I might add, if you further define what carbohydrate intolerance means and what's happening, and there's many things happening that sort of fold into what we consider carbohydrate intolerance, but fundamentally what's happening is when you consume carbohydrate, if you're processing that in a healthy way, it's primarily being oxidized into carbon dioxide and water. You use it as fuel in muscle primarily. When you're carbohydrate intolerant, a significantly greater portion of the incoming dietary carbohydrate is actually being converted to fat in the liver. So it's this mismanagement of dietary carbohydrate that is fundamental to the carbohydrate intolerant state. And so if you follow sort of that metabolic path, if you're processing carbohydrates by converting them to fat, so de novo lipogenesis, there are several downstream events that you could predict, such as your triglycerides would go up in your blood, that you start to show a certain lipoprotein cholesterol particle size pattern in your blood, characterized primarily by a predominance of the smaller LDL particles, and this may be related to lower HDL. And of course, this can lead down the road to higher blood sugars and perhaps other features of metabolic syndrome. So I think if a person starts to show more of these features, that's a harbinger that they're exceeding their body's carbohydrate tolerance, and that they need to dial it down to get back into a level where they can manage it healthy. But that varies from person to person, but those are some clinical tests that could be used to give you some resolution on that.
So interestingly, I think this dovetails nicely into the whole idea of, okay, there's weight loss and then there's maintenance. So how does one determine what carbohydrate level would be right for people on maintenance? And how does one ultimately effectively reintroduce carbohydrates on maintenance if they've been on a carbohydrate restricted diet?
Let's reverse engineer that.
Oh, perfect.
Because in maintenance, it means your weight is not changing day to day, week to week, or even year to year. That means that the fuel coming in eventually has to be equivalent to the fuel being burned. So if a person is reasonably carbohydrate tolerant when they get to the point where they want to hold their weight stable, you can introduce carbohydrates back to the point where they begin to bump up against the point that their level of intolerance. So as Jeff implied, if you measure blood triglycerides, and they started out with high triglycerides, they lost considerable weight, their blood lipoprotein pattern got better, and then you retest the triglycerides at, say, 3 months into maintenance, and you see the triglycerides coming back up, they've probably gotten a little bit above where they should have been. They need to dial down in grams per day of carbohydrate. And that might be, in our experience, for people who have significant weight to lose or signs of metabolic syndrome, the upper end of carbohydrate tolerance for those people, even when they're normal weight, may be 100 to 150 grams per day. Most of those people should not go back to a high carbohydrate diet if they've gotten in trouble on high carb before. So at 100 grams per day of carbohydrates, that's 400 calories a day. Now, most low carbohydrate diets, in fact, most diets that are good for human beings, are going to be moderate in protein. This idea that that low carb equals high protein is a dangerous myth. Yeah. Because we humans don't burn protein very well as fuel. If you have a dog, your dog is very good at burning protein for fuel. But we humans, moderate protein. So for me, maybe 100 to 150 grams of protein per day. It's about 4 calories per gram. So that's between 400 and 600 calories. I don't want to get too technical. But let's say I don't, but I'm over here eating 100 grams of carb a day, that's 400 calories. 150 grams of protein, that'd be 600 calories, 1,000 calories. But I'm a 75 kilo, 165 pound guy. I'm still pretty physically active, and I burn over 2,500 calories a day. But between even the 100 grams a day of carb and the 150 grams of protein, I've only got 1,000 calories. The rest has to come from fat. So you introduce back carbs to the point of carb tolerance. You keep protein moderate because humans, A, protein costs a lot, B, we don't feel well if we eat way too much of it. So protein in moderation, and then the remaining fuel that you need for maintenance will come from a healthy mix of fats. And that's how we put together what we have termed a well-formulated carbohydrate-controlled or carbohydrate-restricted regimen that allows people not just to lose weight reasonably easily, not easy, but more easily than on other dietary approaches, as shown in Chris Gardner's study, but then how one can make it last for decades, not for 6 months or so.
Can you elaborate on what constitutes a healthy mix of fats, and why, for that matter, I guess?
Okay, this gets into dangerous territory because as I mentioned before, when you take carbs out of the majority of carbs out of a person's diet and train their body to burn fat, how the body manages fat, the specific types of fat, changes dramatically. I mean, it's remarkable how differently the body's economy of fat occurs. When you're eating a high carbohydrate diet, not only any saturated fat that you eat is probably going to get tucked away and stored. In addition, if you're carbohydrate intolerant and eating a high carbohydrate diet, and some of that carbohydrate, as Jeff implied, is being made into fat, the majority of the fat made is saturated fat. So you've got a tendency to collect saturated fats on a high carbohydrate diet. If you go on a low carbohydrate diet and adapt the body to burning fat, the first fats in line to get burned are the saturated fats, then the monounsaturates, and then the polyunsaturates. And so you completely shift the body's economy of saturated fats, and if they're getting rapidly burned on a low carbohydrate diet, they're not collecting, they can't do you damage. So this whole idea that saturated fats are bad is only when you're eating high carb. If you're eating low carb, saturated fats are now your body's preferred high octane fuel. They disappear, they can't do you harm. So the mix of fats to burn, where fat is most of your fuel, should be monounsaturates, and to some degree saturates are okay.
Describe a little bit where monounsaturates versus saturates come from.
Okay, we crudely put fats into three categories. There are these things called polyunsaturates, which include the class is called essential fats, and they have a good name over the decades because we used to think they didn't raise cholesterol, and each human needs a modest amount of those each day. We don't use them for fuel. We use them to maintain certain key elements of membranes in the body. So those are what we call polyunsaturates. Monounsaturates are fats that have just what's one double bond in them, and typically we would think those come from olive oil, but there are other good sources of those now, such as high oleic safflower oil and canola oil. And when you examine what humans store under their skin for fuel, said he, pinching a spot, humans tend to store a majority of monounsaturates, even if you don't eat a majority of monounsaturates. And what that implies is, what I've got stored here is what my body has stored for a rainy day. It's what my body wants to burn if the outside fuel supply is cut off. But it also means that it's what the body wants to burn when it's burning mostly fat. Because if you lock me up here in this room and leave me here for 3 days, by the second day, most of what I'm burning is going to be what I have stored. It's what the body wants to burn when it's burning mostly fat. So when we look at that as a kind of a signpost of what mix of fuels to burn, it turns out that we humans store mostly monounsaturates, a fair amount of saturates, and a modest amount of polyunsaturates. And it's using that guidance that helps us recommend the mix of fats that make good fuels. So it means if we're cooking or we're formulating foods, making salad dressings and marinades and things like that, we use a relatively high mono oils such as olive, canola, and high oleic safflower. But we don't shy away from, naturally occurring fats and meats. We don't shy away from butter and cream and things like that. We don't make them our dominant fuels, but they add nice mouthfeel. And we know if we're adapted to a low carb state that what we eat today is going to be CO2 and water tomorrow. It's going to be bye-bye because those are the body's preferred high octane fuels when one is in this adapted state.
Can you specifically talk about omega-3 fatty acids and what the potential benefits of that might be?
And at this point, Dr. Volek is supposed to say, don't ask him that question. Omega-3 fats were identified from marine sources, fish, oil sources. And they became very interesting to us in the nutrition field about 40 years ago because of two things. One is that when we looked at people in European origin populations and looked at the amount of cold water ocean fish they ate, if you ate 3 fish meals per week, and this is seen in populations in Great Britain, in Netherlands, and in North America, if you ate 3 fish meals per week, you had half the risk of having a heart attack as if you ate less than 1 fish meal per week. And we tie that to these things called omega-3 fats, which are anti-inflammatory and do things to components circulating in the blood that reduce the tendency to form blood clots and reduce the tendency for plaques in our arteries to expand and block off blood flow. But we also know that omega-3 fats, and we've learned in the interim, that omega-3 fats do many other things. The majority of membrane fatty acids in the human brain are omega-3 fats. And if you don't have enough, for instance, during gestation and early infancy in children, it affects developmental milestones. So having enough omega-3 fats in early childhood clearly has an effect on development. So omega-3s are good for infants and children. And we're also realizing now that for people who are prone to dementia, so-called Alzheimer's disease, that a constant intake of omega-3 fats in moderation over the adult years has a protective effect. And whether that's because of its effect on membrane function or whether it's the reducing degree of inflammation, those are still issues that are out. But a modest amount of omega-3 in one's diet consistently over the life cycle is important for human health.
So there have been a bunch of terms thrown around, from keto adaptations, ketones and ketone bodies. Can you elaborate on kind of what is keto adaptation and why is that important on a low carbohydrate diet?
Ketones are substances the body makes from fat when insulin level is low and stays low for more than a few days. And the reason that the body makes ketones, if we kind of figure out why the body works this way, is that the brain, human brain, whether we're playing tournament chess or watching television or sound asleep, the human brain burns 600 calories a day. Think of it, it only weighs 3 pounds and it burns almost a third of the body's total energy supply per day. Very high demand for fuel in the human brain. The brain can only burn two sources of fuel, either blood glucose, blood sugar, can't burn fat, but it can burn ketones made from fat. But the only way you get ketones made from fat is keeping keeping carbohydrate intake down, insulin level down for more than a couple days, and then the liver starts making fat into ketones to provide an alternate fuel for the brain. Now, ketones are not a poor substitute. It turns out when you study brain metabolism, the brain is just as effective burning ketones as it is burning glucose. So it's an equally efficient and effective energy source for the brain, but you only get there by keeping carbohydrate intake low for a sustained period of time. And that's why we came up with the term keto adaptation.
And how long does keto adaptation take?
It depends on what you're looking at. If you're looking at well-being when you're at rest, the first week of making that adaptation is tough. After you get through the first week of carb restriction, most people, when they're at rest, feel okay, unless they try to exercise. And if you try to exercise hard at the end of the first week or into the second week, you don't get very far before you feel like someone pulled your plug out of the wall and you just ran out of power. But by the end of the third week, and we demonstrated this in 2 studies we published 30 years ago, by the end of the third week, endurance exercise performance is completely back to where it was before you started carb restriction. So this whole idea that you need carbohydrates to do vigorous endurance activity is a myth. And we debunked that myth 30 years ago, but it persists, and we're still trying to tamp that one down.
Does the ketotic or fat burning process help suppress appetite as well?
Well, appetite is a very complex thing to measure. If you look at overall human satisfaction under controlled conditions, when you take somebody who, particularly somebody who's insulin resistant, who tends to go through wide swings of fuel supply in the body between meals, if you put that person through a couple weeks of keto adaptation under controlled conditions, they'll tell you they have less appetite and less thoughts of food, feeling of need to eat, and a better sense of energy over the course of the day.
So why, after all that, if that's the case, why do ketones have such a bad name?
Excellent question. And it probably stems from the fact that one of the first victories of modern medicine, when physicians stopped being empiricists and started doing research, one of the first victories of modern medicine was discovering insulin and learning to treat the childhood onset, what we used to call childhood onset or type 1 diabetes. That's a type of diabetes where the body doesn't make insulin. And if you don't give insulin, the person dies. And when you have a type 1 diabetic who hasn't gotten insulin for a couple of days, their body goes out of control. They make ketones way out of proportion to what the body can use. And they go into what's called ketoacidosis. And they develop very high levels of ketones in the blood. Whereas when you restrict carbohydrate intake, which keeps insulin low but not zero, those people develop what we call nutritional ketosis, which is only 1/10 as high as ketoacidosis. But doctors have learned, and in the textbooks you learn about ketoacidosis, very few medical textbooks discuss nutritional ketosis. So most doctors, dietitians, and nurses, when they hear the word ketone, they think disease, they think imbalanced metabolism, and that's why I think the bad name persists in the face of very sound evidence that nutritional ketosis is a controlled metabolic state with many beneficial effects.
You know, a lot of what Steve has talked about in terms of the brain adapting to ketones, this is not theoretical. There are several very elegant studies that have studied this and shown that, you know, over half the brain's energy demands can be met by ketones. And I think the other exciting point to make is that there is a very broad interest now in use of ketogenic diets to treat neurological disorders, and this has been very well studied in kids with intractable seizures to treat epilepsy, and there's some very good friends and colleagues of ours who are sort of leading that charge now, and that's been around for quite a while. It was used less frequently with the introduction of several drugs, but according to our friend, that the ketogenic diet for treating seizures has really seen a resurgence, and it happens to be very effective, especially in kids who may be non-responsive to drugs. But it's also expanding into other neurological diseases, and so I think we'll see in the next 5 or 10 years quite a lot of research done on other diseases, Alzheimer's, Parkinson's, and other types of neurological disorders. So there's something happening in the keto-adapted state that changes the fuel, perhaps changes the oxidative stress. The neuroendocrine system is probably adapting in a way we don't really understand all the mechanisms, but it's responding in a positive way that is fueling the brain better and perhaps having a beneficial effect on the pathophysiology of some of these diseases.
Is there a specific role for salt intake during nutritional ketosis?
The simple answer to that is yes.
Can you describe what that might be and why that's important?
Yes, and that is when people go on diets, as the generic term diet, which implies calorie restriction. Most people will naturally think to combine that with salt restriction, because we have been told for 3 decades now that eating salt is bad for us. And as I had mentioned previously, when you eat a high carbohydrate diet, your kidneys tend to retain salt. So salt is collected in the body. When you are keto adapted, your kidneys clear salt, which is a good thing in general for many things. But if you combine a keto adapted state with a low salt intake, you might get too low in salt intake. And salt is necessary for life for humans. There is a modest amount of salt that we must have in our body. It defines our circulation. And if you get too little of it, you may impede blood flow in a way that will make you feel lightheaded, dizzy, get chronic headache sensation, and make it very uncomfortable to try to exercise beyond getting warmed up. Because when you warm up, warming up means you increase blood flow to your skin. You have to have enough blood to go around to feed your muscles that you're exercising and cool you in your skin. And if you're salt restricted when you're keto adapted, you'll turn pale, you'll feel clammy, and if you keep exercising, you'll probably pass out, which is not going to encourage you to keep on being vigorous, which we like to encourage a vigorous lifestyle. What does that mean? That means that when people are in a keto adapted state, they need a day by day, a modest intake of salt. And that doesn't mean you eat a high salt diet. It just means you have to have a modicum of salt. So if people aren't using a lot of salt in their food, we encourage them to have 1 to 2 cups of a moderately salted broth per day. And I actually encourage people to make their own homemade broths, which are much more nutritious than someone can buy, and include that in one's daily regimen to maintain a sense of well-being and function, whether you're dealing with heat stress from a hot shower, being in a hot tub, or going out and doing something vigorously active that causes you to burn a few hundred calories and get warmed up. So again, it's not a high salt intake, it's just making sure that there is a certain minimum requirement that's met that maintains well-being and function.
Do you think that's part of the reason? Do you think sodium depletion could be part of the reason people sometimes feel tired during the first couple weeks of a ketotic or a low-carb diet?
Absolutely.
What are the other reasons that might occur?
Well, the other symptoms that occur along with that, not to get too clinical here, but in addition to avoiding lightheadedness, dizziness, headache, and sense of fatigue, people tend to become constipated. And most dietitians will say, oh, you don't have enough dietary fiber. But it actually turns out that that's a problem in part of fluid balance, and maintaining a modest amount of salt and water coming in avoids some of those complications that are frequently associated with low-carb diets and blamed on inappropriately on other things, where really it's just a matter of simple salt and water.
So are there any other nutritional supplements or electrolyte replacements that one should consider during nutritional ketosis?
We have coined this term of a well-formulated low-carbohydrate diet. And there's not one, but there is a range in which people of intakes. And one of the surprising things that people come across when they read our 2 books that we've written about carbohydrate restriction is that we recommend people eat a lot of vegetables and even modest amounts of relatively low sugar fruits as part of a well-formulated low carbohydrate diet. And part of the reason for that is to get in a range of micronutrients, including an adequate mineral called potassium, which is needed for muscle function and cellular function. And if one has a well-formulated low carbohydrate diet, one doesn't need a whole lot of additional supplements. And actually, Jeff has done some dietary analysis of the low carb diet and compared it to a quote balanced diet in terms of range of fruits and vegetables.
Yeah, and the numbers speak for themselves of people when they consume a variety of vegetables and foods still very low in carbohydrate. They do consume an adequate intake of micronutrients, vitamins, and minerals, so there's really no problems as long as they're consuming a variety of those, in particular the vegetables, low starch vegetables.
Yeah, I was going to say, what vegetables specifically might you recommend?
Well, it's typically the low starch ones. So you're still primarily avoiding potatoes and rice and cereals and grains and so forth because they're higher in carbohydrates that would knock most people out of a ketosis. So that leaves more the non-starchy vegetables, the salad vegetables, and more colorful vegetables that are appropriate in most cases.
But that includes things in salads such as cucumbers, celery, the whole range of leafy greens. And there's more than iceberg lettuce in our grocery stores these days. So there's and the whole range of broccoli and mustards and things like that. And particularly here in the West Coast with the Asian influence, we have a panoply of mustard, broccoli type vegetables, which have a wonderful range of textures and flavors that can be included in the diet.
And part of the reason they are compatible with nutritional ketosis as well as most vegetables contain a fair amount of fiber, which has a rather minimal impact on someone's blood sugar levels and also the insulin response to those foods. So they tend to be compatible with maintaining a state of ketosis.
So moving away from that into exercise, sort of broadly, what role, if any, do you think exercise plays in weight loss? And then as a follow-up, what role does exercise play in weight loss maintenance?
Well, I think this simple answer from our perspective, it may not be the most popular answer, is that the way people respond to exercise in terms of weight loss is highly variable. So there is clearly a genetic component in terms of your response to exercise, and probably the strongest piece of evidence we have to backstop that statement are studies that were done in identical twins who do have the same genetic makeup. And some of this work was done under very rigorously controlled situations where they had twins exercise for 2 hours per day over a period of about 3 months, while they maintained a calorie level that would maintain their weight if they weren't exercising. So theoretically, they should have lost weight due to the extra energy expended during exercise. And the results were rather striking. Over that 3-month period, the different pairs of twins lost, in one case, only a couple pounds, and there were several pairs of twins that lost a little bit more, and really only one pair of twins that lost the predicted amount of weight that you would expect based on the caloric expenditure. So what that tells us is that genetics play an important role in whether or not you will lose weight in response to endurance exercise. The other really important point from those twin studies is that there was a high degree of uniformity within a pair of twins. So if you didn't respond to exercise, your sibling also did not respond to exercise. Again, supporting this idea that it really depends on who your parents are and your genes.
So in thinking about the population at large, would your sort of consensus statement be that exercise is a weight loss tool or is not a weight loss tool?
I think that a well-formulated low-carbohydrate diet given to somebody who has considerable weight to lose will be a very effective tool of initiating the weight loss in that individual. Somebody who carries 60 extra pounds. I see people out, jogging with 60 extra pounds of weight, and I know that they can, if they were normal weight, they'd have to jog 350 miles to lose 10 of those 60 pounds. 350 miles of jogging for 10 pounds of body fat loss if they're translating all the exercise into weight loss. And to me, I say, which is a better tool for that 60-pound overweight person? A well-formulated carbohydrate-restricted diet or exercise? So at the outset, to me, the better tool is get weight off by an effective dietary intervention. And when they are reduced, they don't have to be all the way down to a quote, normal body weight or a goal or target weight, but get a fair amount of the weight off and then add in the exercise and have them experience, because it shouldn't be painful. It shouldn't cause joint and muscle and tendon damage. You don't want collateral damage from the exercise when you have people do it, and have them feel their way into it. Some people will find that A, they love doing it, and B, it seems to help them lose weight. That might be from the twin pair in the study that got everything back from it that they put into it. But we know, and from my clinical experience, and then from this very well done controlled study that was done in Quebec and published 10 to 15 years ago of the identical twins, there were some twin pairs who only got back a quarter in terms of weight loss of what they've been into it. That's a very low return. So for some people, exercise is a weight loss tool. Other people, it's not. We don't yet have a finger prick test that can tell you whether you are the responder or the non-responder. You have to try it and feel your way into it. But if you as an individual try the exercise and you don't think you're getting from it what you want in terms of weight loss, don't make that your primary weight loss tool. Now, fast forward to maintenance. If you get somebody significantly reduced in weight and they find forms of physical activity that they enjoy doing because it makes them feel good, or they do it with other people, so it's a socialization thing that lets them share with other people. That is, when people find something that's right for them, and then you look at who succeeds at long-term weight maintenance, the people who are more physically active are ones who maintain better. So again, it's an empiric process of finding what's right for you and then pursuing that long-term. And those but by taking that kind of soft path approach seems to have the highest yield in terms of giving people the best yield of an outcome of weight control for the effort they put into it.
Okay, so separate but related question, how does limiting carbohydrate intake affect our ability to exercise?
In the first week, like I said, it feels like you pulled your plug. The second week, you can go in moderation. Third week, you can begin to go back to what you did before. By 6 weeks into the keto adaptation process, we've tested high-performance athletes who are keto adapted for 4 to 6 weeks. And at the 4 to 6 week time point, both their peak aerobic power, that is the highest energy they can put out, is unimpaired by having them on a very low carbohydrate keto adapted state. And their endurance time to perceived exhaustion is unimpaired. So that, in terms of aerobic response, there's no limitation. Jeff has done studies with people in resistance training, and he can respond to the resistance training part of that question.
Well, yeah, I work in a kinesiology or exercise science department, so we're very interested in exercise, and I will just say as a general statement, in terms of athletes and coaches and trainers, I mean, there is a profound love affair with carbohydrates. So this is even more heretical to suggest that an athlete could actually function at all, let alone well, on a low carbohydrate diet. But yet the evidence, as Steve alluded to, he's done work, and we've also done work when you allow them time. This is the key variable. When you allow them at least a couple weeks to adapt, their performance can be maintained or perhaps even improved because of the enhanced fuel flow. And there's a very robust adaptation to switch from using carbohydrates as fuel to predominantly fat as fuel. And I think we've very much underestimated the capacity of the human body to burn fat at high rates during exercise. There's a belief that carbohydrate is the preferred fuel for an active muscle, and that fat can only be burned at a certain rate. But based on some of the calculations we've made, humans, when they're keto adapted, can burn fat very rapidly and sustain high levels of exercise.
Like I said, it becomes a high-octane fuel in the keto adapted state.
Are there certain types of exercise for which a low-carb ketotic state might be better?
Well, there are, every sport varies in terms of the metabolic and physical demands. I think the sport that comes to mind as being the most perhaps well paired with a low-carb diet is the ultra-endurance, where you're looking at exercising for 2-3 hours or longer, where you inevitably run out of carbohydrate fuel. We can only store about 2,000 kilocalories worth of carbohydrate on board in the form of glycogen at any one time, and you can burn through that in a marathon. You'll surely burn through it in a triathlon or anything longer. And that athlete, when they hit that point, it's sometimes called hitting the wall or bonking. That is a serious fuel crisis, especially for the brain, because it's looking for glucose and it's not there. And so it starts to get very angry and shut down, muscle contraction and a host of other events that really terminate exercise. And there's a strong drive to seek out carbohydrates to provide that fuel. But when you're keto adapted, the brain has a steady source of fuel by way of fatty acids and ketones for the brain. And so we've talked with several endurance athletes who are keto adapted who tell us that they're bonk proof, that they don't hit the wall. And so this is this is one type of exercise that I think is very well suited to a ketogenic diet. But we also, I'm a power lifter, so I'm at the other end of the spectrum in terms of the metabolic demands, where cycling for a couple hours involves several thousand repetitions I tend to do 1 or 2 repetitions, and that's a workout for me, but at very high intensities and loads. And I've managed to do quite well at a sport that is very metabolically demanding, but in a different way. And there's a range of different sports where we know athletes are performing at a high level. So I think it's compatible with a range of different activities and sports and intensities.
So say that someone's in a keto adapted low carb state. Before they exercise, would you recommend they eat or drink any certain things? And after they exercise, would you recommend they eat or drink any certain things to help their muscles replenish or to help them get through that exercise in a state of happiness and maximum ability to do work?
Well, this is an issue around timing of nutrition, which is a kind of a buzzword now in the sports nutrition world. And there's a lot of evidence that consuming the right carbohydrates before, during, and after exercise is important if you're following a high carbohydrate diet. However, Steve and I have talked about this at length. When you're keto adapted, you're in such a different metabolic state where you're, again, burning your body fat as fuel, and you have ketones to burn as fuel, that the importance of providing pre-exercise nutrition or post-exercise nutrition becomes less of an issue. And so our general feeling is that's not as important to focus on those types of things. Even protein, a lot of the strength athletes really push protein supplements after exercise as a way to promote muscle building and anabolism and so forth. But there's actually evidence that the ketogenic diet preserves lean tissue, may have a protein sparing effect. In particular, levels of some of the essential amino acids, particular leucine, that is of a lot of interest now because it actually activates protein synthesis in muscle, that amino acid goes up in the blood when you're in a keto adapted state. So for a number of reasons, the importance of timing of nutrients around workouts and around competition becomes less important than when you're not keto adapted.
So given the natriuretic state that you talked about earlier in the low carb, low insulin state, how about fluid replacement or electrolyte replacement prior to exercise in a low carb state? Is that more important, or is that something you would emphasize?
Well, hydration is important in any event where you A, have to warm up, and B, if you're exercising in an environment where you lose considerable water. Even if you're cross-country ski racing on a 60-kilometer cross-country ski race or 100-kilometer cross-country ski race in the winter, fluid replacement is important because of expired fluid loss. But in the keto-adapted state, because you carry less water volume in the body, you have less fluid to expand the circulation. So the one caveat that I offer people is that for the keto-adapted athlete, before they do an event that's going to involve them warming up and doing an extended duration of performance, that they take half a pint to a pint of water immediately before the event, so that as they're starting out the event, this is a prolonged event, they're absorbing the water and they expand their circulating volume that way. That way you don't, for me on the bike, I don't hit my water bottle in the first 15 minutes of the ride. I wait until 45 minutes in the ride before I start hydrating because of evaporative losses.
And sodium, not as much of an issue, you think, just in general?
No, as long as you maintain adequate sodium intake. And for me, that means a couple times a day I have a couple cups of broth, or broth that's made into a cream soup preparation, for instance. So I have a fair amount of soup and broth in my dietary regimen. I have in my refrigerator, I have homemade broths that are there for regular consumption, and that I found that is an important part of having my well-formulated low-carbohydrate regimen. The intriguing thing about inflammation is, up until recently, it was all about heart disease, and that happened in the 1990s, where first it became apparent that a person's white blood cell count within the normal range was a predictor of heart attack risk. But The next step after that was the discovery that inflammation predicts your chances of developing diabetes, type 2 diabetes in the future. And now we're looking at a whole host of chronic diseases, ranging from Alzheimer's disease to many of the common forms of cancer. And inflammation is, but it's such a vague concept. It's very hard, and there's no one single number that one can measure. It makes it hard to get a lot of granularity to that.
So, but what dietary steps can one take to modify or lower their level of inflammation?
Well, the one that everybody knows about is fish oil. It's anti-inflammatory. And that is thought to be part of the mechanism by which a moderate intake of fish or supplementing the diet with a modest amount of the so-called fish oil omega-3 fats is associated with a reduced risk of having a heart attack. Or if you do have a heart attack, a reduced risk of sudden death as a result of that heart attack. So the omega-3 fats have garnered a whole lot of attention, and certain popular authors have written whole books about that have been sold to the public as being the big picture about inflammation. But it's actually much more complex than that. It's clear that fruits and vegetables that have a lot of color contain things that are generally called anthocyanins or polyphenols, which are known to have anti-inflammatory properties and beneficial effects when included in the diet. But the really intriguing observation is one that has been predominantly done in studies in Jeff's lab, when we look at well-formulated low-carbohydrate diets in comparison to a well-formulated balanced diet, both of which contain a reasonably comparable amounts of fruits and vegetables. So it's not a difference in fruits and vegetables. The one that comes out ahead in reducing inflammation is the carbohydrate-restricted diet. And so the concept almost is turn it the other way. Carbohydrates may be pro-inflammatory. Taking away carbohydrates brings the body back to its more naturally uninflamed state. And the role of fruits and vegetables in both diets is positive, but the fruits and vegetables may be much more necessary on a high carbohydrate diet because of the pro-inflammatory effects of the carbs. Now this is pure heresy when you state it, but the data supports this perspective. Am I wrong in that? Or?
I think you're right on.
Are certain carbohydrates more pro-inflammatory than others? Specifically, are refined carbohydrates and sugars worse? Or?
It appears that ones that make insulin go up more dramatically tend to be more pro-inflammatory, so they're more refined. But that's not universally true because half of table sugar is glucose, but the other half is fructose, which has been gotten into the news in terms of high fructose corn sweetener. And in animal studies and in human studies, it appears that fructose, which doesn't affect insulin all that much, is a fairly potent pro-inflammatory stimulus. So it's the amount of carbohydrate, it's the degree of refined, but to some degree certain types of simple sugars tend to be more inflammatory, pro-inflammatory than others. But none of the sugars and starches that are commonly consumed in our diet are anti-inflammatory. It's not like they're perched in the middle and some are good for you and some are bad for you. When you start looking at carbohydrates with a cold, hard, scientific eye, on the scale of inflammation, they all go to the negative side. It's just some are more negative than others, but as a group, the carbohydrates tend to promote inflammation, which means that maybe the reason why we, living in a relatively high carbohydrate world, regard fruits and vegetables as very important for health is they need to counteract the pro-inflammatory effects of all this carbohydrate that we're eating in our diet.
And how about with omega-6 fatty acids? Would you describe those as pro-inflammatory in the doses we currently consume them?
There are some currently very prominent authors in the literature who do make that simplistic categorization of omega-6 fats. What's important is the first essential fat ever discovered for mammalian, human and mammals are omega-6 fats. We have to have a modest amount of omega-6 fats for life, but that, for well-being and function in our lives. But that's maybe a teaspoon per day of omega-6 fats. But omega-6s are a category where more is not better, because if you have a buildup of omega-6 fats on a very high omega-6 intakes, a number of of things have been shown in animal studies to get worse rather than better. So you almost can think of omega-6s and omega-3s as a teaspoon each per day. If you're eating a very low-fat diet, those 2 teaspoons of fat are a fairly prominent component of your diet because you're eating so little fat. Say, 10 tablespoons of fat per day. 2 teaspoons is a fair amount. But at the other end of the scale, where someone like me is eating over 1,000 calories of fat, that's well over 100 grams of fat per day. That 2 teaspoons is a very small proportion of my daily intake.
So do you necessarily recommend that people proactively try to limit omega-6 fatty acids, or not necessarily?
If you're in a maintenance phase where fat is necessarily a significant, if not major part of your total daily energy intake, one should steer clear of rich sources of omega-6s to avoid getting too much. So that's why I recommend, when we talked about preferred oils, I mentioned high monounsaturated oils like olive, canola, and high oleic safflower, which are, because they're high in monounsaturates, they're relatively low in proportion of omega-6s, which are polyunsaturates.
And how would you minimize omega-6s specifically? What types of things might you avoid trying to eat? And a separate question, but are monounsaturated fats considered anti-inflammatory? And where else can you get those other than from oils?
Monounsaturates, people will vary. Depends on whether you're eating if you eat a Mediterranean diet, which has lots of dark vegetables and dark fruits in it, people say that's an anti-inflammatory diet, but it's not the olive oil in the Mediterranean diet that's anti-inflammatory. The monounsaturates tend to be relatively neutral in terms of inflammation and inflammatory responses in the body. And the way to not get too much omega-6 fat is to stay away from the vegetable oils that are very rich in omega-6. And again, I don't want to demonize any one particular product, but as a general rule, the current commonly used seed oils in our food industry, which are soybean oil, corn oil, cottonseed oil, and some forms of sunflower and older forms of sunflower and safflower, are very rich in omega-6. If you're on a very low-fat diet and you want to get enough of the essential fats, those may be good components of a very low-fat diet. But if you're on a high-fat diet, those would not be the preferred. In fact, those would be the forms of oils to avoid. So soy, corn, cottonseed, and peanut oil as well.
So are there any specific individuals or people with certain diseases or diseases they'd want to prevent who might specifically benefit from an anti-inflammatory diet, the type of anti-inflammatory diet that you're describing?
Well, we know that chronic higher levels of sort of the basal inflammation is an important risk factor for development of diabetes and heart disease, if not one of the best predictors of your chances of developing those chronic diseases. So, if you have a high level of C-reactive protein, for example, is often looked at as sort of a good overall marker of somebody's systemic level of inflammation. If you have a higher level of CRP, it puts you at a higher risk of developing these diseases. So I think, first of all, those people who have higher levels of these constitutive markers of inflammation would be candidates for low carbohydrate diets. And I would just add on to, Steve talked about low carbohydrate diets being anti-inflammatory, and I would actually consider that a sort of additional facet to the term carbohydrate intolerance. There are people that, there's evidence that if you're insulin resistant, or if you actually do have an inflammatory response to carbohydrates, and it's probably mediated through the insulin response and the role that insulin plays on some of these inflammatory markers and production of these cytokines and so forth. So I think it's part of our definition of carbohydrate intolerance is also an inflammatory response to carbohydrates, as well as a propensity to convert the carbs into fat and so forth. So I think it's the same people that tend to convert carbs to fat that also tend to have an inflammatory response to carbohydrates, and so they are also the groups of people that are most well suited to benefiting from a low carbohydrate diet.
This may be a good chance to dovetail in the idea of metabolic syndrome. So can you describe what is the metabolic syndrome?
Well, functionally, the metabolic syndrome I would describe as a bit of a red flag that you are on a path to developing diabetes and perhaps heart disease. And another way to say that is it's a sign that if you have a diagnosis of metabolic syndrome, that your body is struggling metabolizing the carbohydrate load that you're currently taking in. So it's an early sign or a harbinger of a unhealthy path, a road that you're going down, and that road involves carbohydrate intolerance, that you're on a path to developing more severe forms of that. So we found that metabolic syndrome is very responsive to carbohydrate restriction. And metabolic syndrome is a term that has been more recently used. It's also been called insulin resistance syndrome or syndrome X, and it involves a cluster of different risk factors that maybe on the surface seem unrelated, but I think most experts would agree that there is a sort of common thread that does link these markers, and that thread is probably insulin resistance. And so it may not be surprising, since we define insulin resistance as a form of carbohydrate intolerance, that all these markers tend to get better when we restrict carbohydrates, and we have quite a bit of evidence to support that statement. But the traditional markers, there are a couple different definitions that people use, but they typically involve obesity, in particular a larger waist circumference or a central adiposity, where people tend to store more fat in the midsection, high blood pressure, high blood sugar, and disturbances in cholesterol, in particular high blood levels of triglycerides and low levels of HDL cholesterol. And so usually, to meet this specific definition of metabolic syndrome, you have to have at least a couple of these markers. 3 out of 5 is usually the sort of benchmark to being diagnosed with metabolic syndrome.
And what happens to a person with metabolic syndrome when they restrict carbohydrates? And would you say, for that matter, is that separate from if they specifically just lose weight?
Well, this is a point of discussion and perhaps controversy, is what's driving improvements in a lot of these biomarkers. Is it weight loss? And there's certainly a lot of the more mainstream consensus followers that think weight loss is the stimulus. Our position, I would say, is that it's more related to the carbohydrate restriction, and we have, again, several lines of evidence that point us toward that. One being, all these markers get better when you follow a low-carb diet, whether it's a weight loss or a weight maintenance low-carbohydrate diet. That's probably the most obvious piece of evidence that suggests it's the carbohydrate restriction having these effects. But we've also done studies where we compare low-calorie diets, low in fat and low in carbohydrate, but they're similar in calories, and we see that the low-carbohydrate diet wins out almost on every marker that you look at in terms of metabolic syndrome.
What for patients in that regard without metabolic syndrome?
Well, I think it's generally the same trend, not the magnitude of improvement is less because they don't have triglycerides that are elevated, they don't have blood sugars that are elevated. So, but the triglyceride reduction is probably the hallmark response to carbohydrate restriction. I mean, there is just no drug on the market now that lowers triglycerides more effectively and consistently than a well-formulated low-carbohydrate diet. But the magnitude of that reduction is dependent on the starting level. So if you have metabolic syndrome, it's likely you have high triglycerides. That almost immediately comes down, oftentimes into a normal range. within a week or less. It's a very rapid response.
In other words, long before the weight loss occurs, the metabolic syndrome biomarkers are normalized. So blood pressure comes down, triglycerides come down, and HDL go up quite promptly while the person is losing the weight. They don't have to have lost the weight to get all those yield, which indicates that it's the carb restriction that's reversing that, not the weight loss that's reversing those biomarkers.
And that, as far as we know, is more effective than any medication.
That's correct.
So why is it not more commonly prescribed as a therapeutic remedy?
Well, there's a whole lot of cultural baggage around carb restriction. You know, when you think about it, you know, our European culture is built around various forms of carbohydrate. You know, for the Italians it's pasta, for the French it's bread, for the Germans it's potatoes. Of course, they didn't get the potato till it emigrated from the New World after the Spanish discovered the potato existing in the Andes. But we talk about our daily bread as almost like life in our culture, and to tell people that there is no obligate requirement for carbohydrates in our diet is really flying in the face of our culture. It's almost un-American or un-Irish or un-German or un-Italian. It's a major leap for people to think that they would give those things up in exchange for a very positive outcome. So there is a palpable degree of reticence, of reluctance to accept something which is at this point scientifically obvious. And I think it just is going to take time. It's going to take conversations like this one. It's going to take people writing books like Gary Taub's Good Calories, Bad Calories, and the more approachable version of that, which is Why We Get Fat. It's why Jeff and I have attempted to write a couple books to make both healthcare professionals and the lay public aware of the potential value to some segments of the populations, those at the greatest risk. Those are the ones who are the most likely to be insulin resistant or carbohydrate tolerant, that it might be worth taking this leap of giving up something which is almost part of our cultural identity in order to achieve a tangible and palpable and perceivable health benefit.
And I would add the other real benefit of using a low carbohydrate diet to treat metabolic syndrome is that if you're a physician trying to manage multiple biomarkers that are out of the normal range, you have to then use multiple drugs to target the high triglycerides. You might take a fibrate or a niacin, and then you've got high blood sugar to deal with, so you have to put them on metformin or something. So you get to polypharmacy. With a low carb diet, since you're treating the underlying problem of insulin resistance, and more specifically the carbohydrate intolerance, you can treat all the symptoms and signs of metabolic syndrome with one intervention, and it's non-toxic if it's done well. So there's very low risk of side effects, and that's not the case with all the drugs. And of course the risks go up as you use more than one drug, which is needed to manage effectively metabolic syndrome.
How does restricting carbohydrate affect our cholesterol?
Well, the effects of diet on lipoprotein metabolism and cholesterol metabolism has been an interest of mine, and it's more than a bit complex. But we've certainly done a lot of work in that area, and I would start off by saying there are a couple markers that consistently change with low carb, and we talked about triglycerides go down consistently, and that's almost always followed by an increase in HDL, which is considered, both of those are considered, very favorable in terms of your cardiovascular risk. Now, most people like to focus in on the LDL cholesterol, though, as a primary target for reducing risk for heart disease. And I have to say, what we've seen with LDL cholesterol concentration is quite variable. You will see some people decrease, perhaps dramatically. You'll see some people increase, and you'll see some people stay the same. So I think there's some genetics going on there. We've seen this in feeding studies where we feed people the exact same diet for 6 weeks, and we see very uniform changes in triglycerides and HDL, but LDL concentration is quite variable.
Independent of weight loss?
Independent of weight loss. So under weight-stable conditions, this occurs. However, what is more consistent is the qualitative features of LDL do improve consistently, which is consistent with what we know about the heterogeneity of LDL cholesterol. Those particles range from very small to larger, more buoyant particles. And it's the smaller, denser LDL particles that are more atherogenic, that are more highly associated with risk for heart disease for a number of reasons. They probably penetrate the arterial wall more easily. They're probably more prone to oxidation and so forth. But some very good work has shown it's those particles that are most dangerous. And we consistently see a low-carb diet makes those LDL particles bigger. And the terms that have been used to describe those smaller particles, if you have more of those, you're considered a pattern B versus a pattern A, which you have more of the larger fluffy LDL. So we consistently see people switch from pattern B to pattern A with a low carbohydrate diet. So even if you happen to be one of the people that see perhaps a moderate increase in your LDL cholesterol level, it's almost always in the form of the larger, less atherogenic LDL particles. And I think there's other reasons that LDL cholesterol may go up in people losing weight rapidly. And Steve made this observation many years ago.
And that is that we think of cholesterol as circulating in the blood. People who study membranes know that cholesterol is an obligate part of human membranes. You have to have it in the membrane for the membrane to work right. So cholesterol, it's been demonized, but it's necessary for life. What is not well understood is that we also store some cholesterol inside our fat cells, along with the triglyceride that's the fuel. But the only fuel in the fat cell we can burn for energy is the triglyceride. The cholesterol can't be burned for fuel. So as you lose weight and you mobilize the triglyceride, the fat cell shrinks. That's a good thing. You want smaller fat cells. That makes you lighter in weight, right? But as the fat cell shrinks, not only is the triglyceride mobilized, but the free cholesterol that's dissolved in that fat droplet is also mobilized. So we noticed this when we were dealing with people with major weight loss. When we looked at people who lost 60 or more pounds of body weight, we frequently saw them, they first go on our weight loss diet, and their LDL cholesterol on average would go down somewhat. Not a lot, just somewhat. But after they passed 30 pounds, went to 40 pounds, to 50 pounds, their total cholesterol and LDL fraction of cholesterol started going up. And sometimes we would see dramatic rises in the LDL cholesterol. So we actually did, it sounds gruesome, but we did fat biopsies on people. We called it mini liposuction, so the patients lined up to have it done. And we'd take little bits of body fat from the thigh or from the abdomen and measure the amount of cholesterol they had stored. And if we looked at people repeatedly as they lost weight, we could show that when they first started losing weight, the fat cells would shrink and retain their cholesterol, but at some point the cholesterol had to then be mobilized. And when we looked at the rate of fat loss, what we saw was that people were mobilizing up to 300 milligrams of free cholesterol from their fat cells that had to go into the circulation. That then has to be picked up by the liver, made into bile, and cleared through the gallbladder to get that cholesterol out of the body. And so that rise in LDL cholesterol during major weight loss was a function of dumping from the body, clearing out from the body, a bunch of cholesterol that had been previously collected and retained. So the good news is, and there is good news at the end of this long story, that after people got to weight maintenance and held their weight stable, fat cells are no longer shrinking. And that very high LDL cholesterol that some of them had gotten because of weight loss came right back down. And then they ended up having gone from a relatively high to a lower LDL. So the net effect of the weight loss was a beneficial change in the lipoprotein profile. But it looked a little scary if you were just focusing just on the LDL cholesterol during the active weight loss phase.
So what happens to saturated fat metabolism during carbohydrate restrictions?
Well, the story of saturated fat is a fantastic story of misconception and deception. I think if we use a crime analogy, when there's a major crime committed, we like to find a culprit and make an arrest. And if we view obesity and diabetes as a crime, I think we've tried to blame saturated fat for a lot of the health problems we have. However, if you inspect the data more carefully, a rather interesting and consistent pattern comes out and this is a story that's not, I think, well understood and certainly not talked about. We're very interested in saturated fat metabolism because we're suggesting that you can eat, and it may be even important to eat a certain amount of saturated fat in your diet. So we have studied this phenomenon. But just to take a step back, if you look at the current analysis of dietary saturated fat and its connection to various diseases, it's actually quite consistent now. Since 2009, 3 major reviews, very comprehensive reviews, have all come to the same conclusion that dietary saturated fat intake is not correlated to heart disease. So looking at hard endpoints here of heart attack, heart disease, mortality, that there's no association. So that doesn't really fit with a lot of the dietary recommendations that we've been promoting for 3 or 4 decades that have consistently focused aggressively on getting Americans to reduce saturated fat intake, and yet the evidence suggests that that's not even related to heart disease. But if you probe a little further and ask the question, is saturated fat completely off the hook here? What if you look at saturated fat levels in the body? And there have been a number of studies that have actually measured saturated fat in blood in different lipid fractions and correlated that to risk for heart disease and diabetes. And the story there is a little different. There is, in fact, a correlation with higher levels of saturated fat in your blood, in your cholesterol ester, your phospholipid fractions of your blood, and risk for heart attack, heart failure, for metabolic syndrome, and for heart disease. So saturated fat levels in the body, not in your diet, are related to higher risk for disease. So,
This is what Jeff is getting to. The point here is that the soundbite we always hear is "you are what you eat," and yet what he's just said is there is a disconnect between eating saturated fat and having a level and having disease outcome, but there's a strong connect between having saturated fats in your blood and having bad outcome. So we're getting to the point of saying, we're not what we eat. And that comes down to what drives saturated fat levels in the blood. And this is where Jeff's research with controlling the amount of carbohydrate people eat during either weight maintenance or weight loss diets, and looking at that effects on saturated fats. And that's really where the piece of this puzzle comes. And he did the work. He'll tell you what it meant.
In collaboration and collusion, maybe, with Steve, we turned our focus on let's measure saturated fat levels in the blood in some of the diet trials that we were doing with comparing low carb to low fat diets in different populations. And so one of those studies, the first one was a study in patients with metabolic syndrome who were assigned to a very low carbohydrate or low fat diet. And they were low in calories, but the low carbohydrate diet in this study contained 3 times the level of saturated fat. 36 grams per day they were consuming, compared to the group consuming a low-calorie, low-fat diet, which had about 12 grams of saturated fat. And when we looked at the saturated fat levels in their blood 12 weeks later, the low-carbohydrate group actually reduced more than the low-fat group, despite eating, in this case, 3 times the level of saturated fat.
Reduced more of the saturated fat in their blood?
Yes.
Okay.
So the biomarker that's associated with poor outcome, which is blood levels of saturated fat, went down on the low carbohydrate diet, even though they were eating more, 3 times as many grams per day of saturated fat. And the only way that can be explained is that in the keto adaptive state, saturated fats become the body's high octane fuel. It goes to the front of the line, gets burned first. If you burn it and make it into CO2 and water, it doesn't accumulate in your body. Can't do you harm. So here's a fascinating paradox. They eat 3 times as much saturated fat. They have lower blood levels, which presumably, based on the really sound research in multiple cohorts, which links risk to levels of saturated fat, that the eating the higher saturated fat level in the context of a low-carb diet results in a greater safety profile. Fascinating paradox. But clearly you are not what you eat, you are what you save from what you eat.
And this is, I think it's important to say, these findings are not an anomaly. It's very consistent with the metabolic fate of carbohydrate, and there were other footprints in the sand that really led us to hypothesize that this would be our finding. Other studies have shown virtually no correlation between saturated fat in the diet and saturated fat levels in the blood. In fact, they show much better correlation with dietary carbohydrate, higher carbohydrate intake being associated with higher blood levels of saturated fat. But no one had really done this at the level of carb restriction we were looking at in our cohort. And then we've validated that work with studies in weight maintenance and normal weight, healthier folks, and essentially found similar results that when your carbohydrates are low, your body is using those dietary saturated fats as fuel and not storing them or accumulating them in the arteries or in your hips, or it's being used as energy.
Well, and what happens?
Continue.
Okay. Within the body, what happens when one consumes an excessive amount of carbohydrates, or maybe rather than say excessive, if one consumes what's the typical American percentage of caloric intake from carbohydrates a day, around 50%. If they eat excess calories in the form of carbohydrates, and what happens to that fuel in the body?
Well, let's take where we don't talk excess calories of carbohydrate. Let's talk about adequate calories overall. So we feed people the same number of calories. And there are 2 studies, one done in Minnesota, one done in Seattle, Washington, that have been published in this last decade, where they kept calories constant, but fed the average American kind of fat intake, say 30% fat, and then cut it down to 15% fat. But when they took away the fat, they gave back, quote, good carbohydrates, not simple sugars, but complex carbohydrates. So they moved from a normal fat to a low fat and replaced the fat that was taken away with good carbohydrates. And what happened in both those studies is the proportion of saturated fat in the blood went up. So as you feed less total fat, less grams of saturated fat, but replace it with carbohydrate, you drive up blood levels of saturated fat without overfeeding, feeding the same number of calories. What that implies is that in many of those people, remember these are generally diverse groups of people, not everybody responds the same, but in many of the people in that group, those 2 groups of people, when they gave them more carbohydrates, they got past their level of carbohydrate tolerance, to the point they're making a fair proportion of that added carbohydrate into saturated fat, and it was accumulating in their blood because carbohydrates on average drive up insulin blocks fat from being burned. So it makes, whereas a low carbohydrate diet makes saturated fats into high octane fuel, the high insulin, high carbohydrate state turns fat into storage fuel, which accumulates, which carries risk.
It's interesting because within the last 40 years, that's sort of mirrors what's happened in the country, it seems, where we've consumed less fat and more carbohydrates. you think that's influenced at all rates of diabetes, rates of obesity?
Well, I think that's a really important point, that our research findings are not trivial, in the sense that what we're saying is actually manifesting itself in this country. If you look at dietary patterns, we have in fact changed dietary patterns, and the most salient change we've made is we've increased our carbohydrate intake, and at the same time our saturated fat levels have gone down. And
Dietary saturated.
Dietary saturated fat levels have gone down, and
But maybe blood levels have gone.
and based on all the science, yeah, we would predict then that as a population, our average blood levels of saturated fat have gone up, even though our dietary saturated fat intake has, if anything, gone down, because we've increased our carbohydrate intake. And I would argue a lot of that has probably been in the form of higher glycemic index, insulin stimulating carbohydrates and fructose, which we know will all work to drive more of that carbohydrate into fat in the body.
So within the last approximately 40 years, I think we've gone from around 5 million people in the country having diabetes to around 17 million people in the country having diabetes. What do you think has been the main source of that change?
Well, again, the dietary intakes, from surveys, large-scale surveys and consumption data, all point to the major change in dietary intake has been in the form of higher carbohydrate intakes. On average, about 50 grams more per day than we were consuming back in the 70s. So I think that is probably the number one factor from a dietary intake perspective driving the obesity and diabetes epidemic, because in a lot of people that's 50 grams is enough to push them over their tolerance, their carbohydrate tolerance. Now, I won't, it's always a risk of oversimplifying things, but if there was one particular pattern or one particular dietary change that's responsible, I think that would be my best guess.
But that's a phenomenon. And people will say, skeptics will always say, but doctor, what's the mechanism? Right. Yeah, you eat more carbohydrate, but what's the mechanism? And we got two smoking guns here. One of them is we know that increasing proportion of carbs in the diet, particularly simple sugars and high glycemic, highly refined carbs, increases inflammation. When you look at well-done multiple studies that take blood samples from people now and then watch them for 10 or 20 years and see who develops diabetes, biomarkers of inflammation are some of the best predictors of who's going to develop diabetes in the future. Right? Increased simple sugars and high glycemic carbs drive up inflammation. Second smoking gun is biomarkers of lipogenesis, conversion of carbohydrate into fat. Those are also potent predictors of who's going to develop type 2 diabetes. And as we've said, when we've looked at well-controlled studies, we and other investigators, when you increase the proportion of carbohydrate in biomarkers of lipogenesis, the production of saturated fats and a certain monounsaturated that is a fairly unique biomarker, those go up. So we have lipogenesis, we have inflammation. Both of those are tightly linked to the pathogenesis, is the underlying molecular cause of diabetes. They go up and it's associated with the carbohydrate. So we not only have the phenomenon in the macronutrient intake, but also we have two smoking guns of mechanism that make, if you were a betting person, you would put big odds on winning by picking those mechanisms as a cause of the problem that you've identified, Sean.